All right. Yeah, we now move into section G, personality disorders, and this is one of the most interesting areas in abnormal psychology because people, usually use these labels very casually, and even online, almost every difficult X, becomes a narcissist, okay, with a narcissistic personality disorder. And then every intense relationship becomes borderline, and every rude person becomes antisocial. And clinically, it is not that simple. Okay, so personality disorders involve enduring patterns in the way a person sees themselves, relates to others, regulates emotions, and behaves across times. That is the key difference. We are not taking mainly about temporary symptoms or short term episodes here. We are talking about something more structural, a long standing way of functioning. So, the big point here is this: personality here is not just style, vibe, or branding. It is part of the person's psychological structure, and when that structure becomes inflexible and maladaptive, it can cause real impairment in work, identity, and relationships. That leads us naturally to the next question. When exactly does a personality pattern become disordered? Okay, let's go to the next slide. All right. A personality pattern becomes clinically disordered when it is rigid, pervasive, and maladaptive. Again, rigid, pervasive, and maladaptive. In other words, it keeps showing up across situations that does not adapt well and repeatedly creates problems. Everyone has traits. Some people are more dramatic, more suspicious, more shy, more controlling, more dependent, more intense. That alone does not mean disorder. The problem starts when the pattern becomes so fixed that it keeps damaging relationships, work, judgment, or emotional life. So, for example, being cautious is not the same as constantly mistrusting other people. Being organized is not the same as being so rigid that you cannot delegate or tolerate imperfection. Being sensitive is also not the same as having chronic emotional instability that repeatedly disrupts relationships. So, the key idea is this: more than a strong personality, a personality disorder is a pattern that is hard to bend. It shows up everywhere and keeps costing the person something important. From there, we can look at the general features these orders tend to share. So, what are the general features of personality disorders? Okay, so personality disorders often involve chronic problems in a few core areas: self concept, emotional regulation, impulse control, relationships, and the interpretation of other people. That means the difficulties are not just behavioral, they also involve how the other person or how the person experiences themselves and makes sense of others. And these patterns are usually long standing. They often begin by adolescence or early adulthood and remain relatively stable over time. Now, that does not mean people cannot improve. They absolutely can. But it does mean these patterns are not just one bad semester or one painful breakup or one stressful life phase. A useful way to think about this is that personality disorders affect a person's default settings. Under stress, how do they react? In relationships, how do they interpret? Closeness, criticism, control, rejection, or dependence. In identity, how stable is their sense of self? So, if previously we answered when a personality becomes disordered, this time we show where that dysfunction tends to live. And now we sharpen the contrast by comparing personality disorders with more episodic conditions. So, here, this slide is very important because it helps prevent a common mistake: confusing enduring patterns with episodic conditions. Disorders like major depression, panic disorder, or a manic episode often come in episodes. They rise, change, and may improve or recur over time. Personality disorders are different. They are more trait like and structural. They shape the person's identity, coping style, and relationships over the long term. That does not mean personality disorders never overlap with other disorders. In fact, they often do. A person can have borderline personality disorder and also experience depression. A person with avoidant personality disorder may also have social anxiety. A person with narcissistic traits may also become depressed under major blows to self esteem. So, the key distinction is this: episodes come and go. Personality patterns tend to organize everyday functioning over time. And once we understand that, the cluster system starts to make sense. So here are the three clusters of personality disorders. Personality disorders are commonly grouped into three clusters. These clusters are not perfect boxes, but they help organize the field. Cluster A is what we call the odd or eccentric cluster. These presentations often involve social detachment, suspiciousness, or unusual ways of thinking. And then we have cluster B, the dramatic or erratic cluster. These disorders tend to involve emotional intensity, impulsivity, interpersonal instability, or attention-seeking patterns. And then, of course, we have cluster C, the anxious or fearful cluster. These presentations usually involve insecurity, avoidance, dependence, or excessive control. The important reminder on this slide is that the clusters are descriptive, not absolute. Real people do not always fit neatly into neat columns. Still, the cluster model is useful because it helps you build a first mental map. And now, we begin with Cluster A. Cluster A, odd and eccentric personality disorders. Cluster A includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. The common themes here are social detachment, unusual beliefs or thinking, suspiciousness, and interpersonal distance. These individuals may come across as distant, mistrustful, emotionally cold, or socially unusual. For example, someone with strong paranoid traits may constantly interpret other people's actions as threatening or deceptive. Someone with schizoid features may seem detached, indifferent to closeness, and more comfortable staying distant from others. Someone with schizotypal features may have odd beliefs, unusual perceptual experiences, or eccentric behavior. What matters clinically is that these patterns create real relational barriers. This is not just a quirk or being introverted or different. It is a consistent interpersonal style that affects trust, connection, and social functioning. From there, we move into the cluster students usually recognize fastest and often see in most dramas. Okay, cluster B. Cluster B, dramatic and erratic personality disorders. Cluster B includes antisocial, borderline, histrionic, and narcissistic personality disorder. The common threads here are emotional intensity, impulsivity, instability, and erratic interpersonal patterns. This is the cluster most likely to get oversimplified online because the behaviors are often dramatic or highly visible. But again, we have to be careful. These are not just difficult people. These are enduring patterns involving emotion regulation, self-image, empathy, control, and relationships. For example, one person may show repeated instability in relationships and a strong fear of abandonment. Another may show grandiosity and extreme sensitivity to criticism. Another may show chronic manipulation or disregard for others, and these are different patterns even though they all sit in the same cluster. So the key point here is that cluster B disorders involve high emotional or behavioral intensity, but each diagnosis has its own structure. Then we shift to cluster C, where fear and insecurity become more central. Cluster C, anxious and fearful personality disorders. Cluster C includes avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. The overall tone here is fearfulness, insecurity, dependence, and excessive control. These patterns can look quieter than cluster B, but that does not mean they are less impairing. Someone with avoidant traits may deeply want closeness but avoid it because rejection feels unbearable. Someone with independent traits may struggle to function independently because separation feels too threatening. Someone with obsessive compulsive personality traits may be so rigid and perfectionistic that flexibility becomes difficult. So if cluster B often looks loud, cluster C often looks tense. These are people whose lives may become organized around fear, caution, approval, or control. And with that background, we can now look more closely at specific diagnosis, starting with borderline personality disorder. Borderline personality disorder, or BPD. This is marked by instability in relationships, self-image, emotion, and behavior. The slide, as you can see, highlights some of the classic clinical markers: fear of abandonment, unstable relationships, intense emotional reactivity, identity disturbance, and impulsivity. A very important point here is that BPD is not just being dramatic or being intense. The person often experiences emotions as overwhelming, their relationships unstable, and the self as hard to hold together consistently. Small shifts in closeness, rejection, or perceived abandonment can feel really huge for them. For example, one unanswered message may feel like proof that the relationship is collapsing. One criticism may feel devastating. One conflict may trigger panic, anger, or despair. The emotional system often reacts fast and hard. So the key point is this: BPD is a disorder of instability. Instability in how the person feels, relates, sees themselves, and tries to cope. From there, we move to another heavily misused label: narcissistic personality disorder. Now, let's go to NPD, or narcissistic personality disorder, and it involves a pattern of grandiosity, need for admiration, and lack of empathy, often paired with a more fragile internal structure than people first assume. This is where students often need a correction. NPD is not simply confidence, ambition, or liking attention. Clinically, it involves self-importance, excessive need for validation, right? Low empathy, sensitivity to criticism, and vulnerability underneath the surface presentation. So a person may look highly confident, impressive, or dominant, but react intensely to being challenged, ignored, or criticized. In some cases, what looks like arrogance is also covering insecurity or fragile self-worth. So the key point here is this: the outward presentation may look strong, but the internal structure is often more brittle than it appears. And now we move to a pattern where disregard for others becomes much more direct. ASPD, or antisocial personality disorder. Antisocial personality disorder involves a chronic disregard for the rights of others. The pattern includes deception, manipulation, impulsivity, aggression, irresponsibility, lack of remorse, and indifference to harm. This is more than being rebellious, rude, or difficult. It is a repeated pattern of violating social and interpersonal norms. The person may lie, exploit, act aggressively, fail to plan, or disregard the consequences for other people. And one reason this diagnosis is important is that it forces us to separate ordinary conflict from chronic violation, because not every selfish or irresponsible person has ASPD. But when the pattern is persistent, pervasive, and marked by indifference to harm, the clinical picture changes. So, the key point is this: ASPD reflects more than difficult behavior. It reflects a chronic pattern of violating boundaries, rules, and the rights of others. From there, we move into a very different pattern, one organized more around fear and inadequacy. The AVPD or AVPD, the Avoidant Personality Disorder, that is marked by social inhibition, feelings of inadequacy, and hypersensitivity to rejection. The person often wants connection, but closeness feels dangerous because criticism, embarrassment, or humiliation feels too painful. And this is what makes AVPD different from simple disinterest in people. The person is not avoiding because they do not care. They are often avoiding because they care so much that rejection feels unbearable. A relatable example would be someone who wants friendship, wants connection, maybe even wants to join groups or speak up, but repeatedly pulls back because they expect criticism or humiliation. So, the avoidance becomes protective but also costly. The key point here is the desire for connection is often present, but fear stands in the way. That makes it very different from detachment based patterns. And now we move to another cluster, C presentation, one based more on control than avoidance. So, obsessive compulsive personality disorder or OCPD. Obsessive compulsive personality disorder involves perfectionism, rigidity, excessive control, and preoccupation with order, rules, or details. This is one of the most important distinction slides because students often confuse OCPD with OCD. Remember, in OCD, the central issue is obsessions and compulsions, intrusive thoughts and repetitive behaviors, while in OCPD, the central issue is a personality style organized around control, precision, inflexibility, and perfectionism. For example, a person with OCPD may struggle to finish work because nothing feels good enough. Alright, they may have difficulty delegating because others do not do things the right way and may become rigid or frustrated when routines are disrupted. So the key point is this: OCPD is not mainly about intrusive thoughts. It is about an inflexible personality style centered on order, perfection, and control. And that brings us to why personality disorders as a whole are so often tricky and misunderstood. Personality disorders are often misunderstood, alright? Because their patterns can look like attitude, stubbornness, toxicity, or just who the person is. That makes them easy to moralize. People often ask, is this really a disorder or is this person just difficult? And the answer is that personality disorders involve deeply patterned dysfunction. Again, deeply patterned dysfunction in self and relationships. They are not just bad manners or strong opinions. At the same time, this is exactly why clinicians have to be careful, because once labels become moral weapons, diagnostic thinking collapses into judgment. So the key point here is that personality disorders require clinical understanding and not moral commentary. They are easy to stereotype but hard to understand as well. And that is why the next slide is about clinical cautions and differential diagnosis. This is so important. Clinical cautions and differential diagnosis. Now, this slide is basically the do not diagnose too fast slide. Personality disorders must be distinguished from mood disorders, trauma-related disorders, psychotic disorders, neurodevelopmental conditions, and substance effects. Why? Because similar behaviors can come from very different causes. Emotional instability may reflect BPD, but it may also reflect trauma, bipolar disorder, or substance effects. Social withdrawal may reflect schizoid traits, but it may also reflect depression, autism, or social anxiety. Rigidity may reflect OCPD, but it may also be shaped by anxiety, trauma, or neurodevelopmental style. That is why we look at the long-term pattern, not just the current snapshot. We also consider trauma, cultural context, and developmental history. So the key point is this: similar behavior does not always mean similar diagnosis. And that brings us to the summary of the whole section. To summarize Section G, personality disorders involve enduring, inflexible, and maladaptive patterns affecting self-functioning, emotional regulation, and relationships. They are grouped into clusters A, B, and C, which help us organize the broad patterns. Cluster A, odd or eccentric. Cluster B, dramatic or erratic. Cluster C, anxious or fearful. But the most important takeaway is this: personality disorders are not just labels, stereotypes, or dramatic descriptors. They represent long-term patterns that require careful clinical judgment. So if I had to reduce this section to one sentence, it would be: personality disorders are less about isolated symptoms and more about enduring ways of being that repeatedly disrupt life. And from there, we are ready to shift to a completely different clinical lens. So our next would be Section H, or neurodevelopmental disorders. This next section shifts away from personality structure and toward disorders involving developmental patterns and cognition. So instead of asking how long-term personality traits shape identity, emotion, and relationships, we now begin asking about attention, learning, communication, development, and later cognitive decline. And this is a major shift in lens because we move from enduring personality patterns to conditions that are often tied to early onset developmental processes or changes in cognitive functioning across the lifespan. In other words, we are leaving the psychology of personality structure and moving toward the psychology of development and cognition. That is where Section H begins. So thank you so much for listening. I will upload Section H as soon as I'm ready with the slides and the lecture itself. Thank you very much for listening. I hope you learned something from it. Good luck if you are taking the boards or something like that. Thank you. See you next time.